Great. So before we begin with the webinar, we wanted to first acknowledge some recent events that have impacted transgender people in significant ways. First, a number of state legislators have recently introduced bills targeting transgender youth and criminalizing the treatment of adolescents with gender dysphoria. Second, on Monday, the Supreme Court decided to allow the Trump administration to implement its new public charge rule. This rule applies to the public charge admissibility test for immigrants who are obtaining lawful permanent resident status. Generally, it revises what officials can consider for the test and can include immigrants' use of some Medicaid services and SNAP benefits. Being considered a public charge weighs against a person's application for this status, and while there's no timeline set out right now, the Department of Homeland Security can now implement this rule across the country, except in Illinois, which still has a statewide injunction against this rule. Because we have time on this webinar, we won't be able to address these current events, but we did want to reserve some space to acknowledge it, and we will be sending a follow-up email with resources on both of these topics after the webinar. So we will go ahead and I'm going to pass it off to Lee, who is going to introduce our first panelist.
Thanks, Marianne. So our first panelist is Christy Mallory, who is the Director of State Fund Policy at the Williams Institute. She focuses on a variety of topics, including sexual orientation and gender identity, non-discrimination protections, state-level recognition for same-sex couples, and other state and local level laws impacting LGBT people. Today, she'll be presenting on the 2019 report she co-authored on Medicaid coverage for gender-affirming care, which does a 50-state survey of Medicaid policies and highlights variation in coverage requirements for gender-affirming care. So I'll let Christy take it from here.
Great, thank you so much for having me today. My pronouns are she, her. My name is Christy Mallory, and I am the State and Local Policy Director at the Williams Institute. And before we get started talking about the report that we recently issued, I wanted to, it looks like, there we go. Sorry, my computer's a little slow, so we're jumping around here. Let me go back. I wanted to talk to you a little bit about the Williams Institute for those of you who may not have heard of us. We are an interdisciplinary research organization housed at the UCLA Law School, and we're focused exclusively on sexual orientation and gender identity law and policy issues. So our experts come from a diverse range of backgrounds. We have people with expertise in law, public health, public policy, economics, demography, and other areas. And our goal is to conduct rigorous research that is disseminated to legislators, judges, and other policymakers and the public to ensure that LGBT-related laws and policies are based on data and facts about the LGBT community and not based on stereotypes. So turning then to the report, we decided to study access to coverage for gender-affirming care for Medicaid beneficiaries and the impact of current policies, because we know that coverage is not uniformly available for transgender Medicaid beneficiaries in the U.S. And that's in part because there's no federal law or policy that requires state programs to provide coverage for gender-affirming care. And while some states, as we'll get into in a minute, have stepped up to fill that gap by enacting policies that expressly require their state's Medicaid programs to cover gender-affirming care, many states have not. So this patchwork of protections leaves many transgender Medicaid beneficiaries without access to coverage for care that is necessary for their health and well-being. So we started by taking a look at the laws across the U.S., the state level laws. So let's get into this and take a look at this patchwork of protections that we see right now. So our research identified 19 states and DC which have express policies stating that Medicaid must cover gender affirming care for transgender beneficiaries. And those states are shown in blue on the map here on the slide. And then at the other end of the spectrum, we identified 12 states that have policies expressly excluding coverage for gender affirming care. And those are the dark gray states on the map. And then there's a group of 19 states in the middle that are silent on whether gender affirming care is covered by Medicaid or not. And those are the lighter gray states on the map. So as I'm talking about laws that expressly provide coverage and laws that expressly exclude coverage, I wanted to just give you a quick idea of what kind of policies I'm talking about. As we reviewed the state level laws in our 50-state survey, what kind of language were we looking for at the state level? So here's an example of a policy that explicitly guarantees coverage. This is from Montana, and I'll give everyone a second to kind of look through that policy. So this policy has a lot of features that we see across the states. And for those of you who are interested in looking at the individual policies, they're all linked in our report. So you can look at your state or a state that you're interested in very easily. And some common features in this one and other policies are that they refer to services that otherwise fall within a member's covered benefit plan, and how they're reimbursable, and specifically when the treatment is medically necessary, a decision made by providers. And then a lot of them refer providers to the standards of healthcare for the health of transsexual, transgender, and gender nonconforming people that was issued by the World Professional Association for Transgender Health. So that's another great resource and document for those of you who would like to look at recommended standards of care. If you're not familiar with them, you should take a look at that. Then turning to a policy that expressly excludes coverage. I have Alaska's here only because it's pretty short. Some of these will get very long, as you see, but you can see the language there that they use. And this is an express policy. It's referring to the health department or the Medicaid office within the health department that administers the Medicaid program, specifically saying that that plan is not going to cover services for gender affirming care. Of course, then we're left with the states in the middle. I have nothing to show you because those states don't have either of those type of policy. They're just silent on whether coverage coverage is available or not. So we did the legal research, and then we wanted to map that onto estimates of the transgender population to figure out the number of people who are affected by these differing policies. And we used data from the U.S. Transgender Survey to do this analysis. And we found that there are an estimated 152,000 transgender people enrolled in Medicaid across the U.S. Oops, sorry. And then looking at them at the policy level, we found that fewer than half of these beneficiaries, about 70,000, live in states with policies that guarantee access to care. And then about 50,000 live in states where coverage is unclear because, as I was saying before, the policies don't explicitly include the coverage and don't explicitly exclude it. And then about 32,000 transgender Medicaid beneficiaries live in states with bans that deny access to care. And then in the final section of our report, we looked at how existing state and federal laws can be used by litigants to secure access to needed care if there's not a policy, or the policy is, if there's not a policy either way, or if there's a bad policy in their state. And we found that there are several laws out there that courts have determined require states to provide Medicaid coverage for gender affirming care. So first, let's look at the Affordable Care Act. So the ACA's non-discrimination provision does not include gender identity explicitly, but it includes sex as a protected characteristic. And some courts have found that gender identity discrimination is a form of sex discrimination prohibited under the law, and as such, that insurance plans covered by the ACA, including Medicaid, must provide gender-affirming care for transgender people. So I just want to quickly flag that this might change in the next few months. I'm sure, as many of you know, the Supreme Court is considering a case in which it will decide whether gender identity discrimination is a form of sex discrimination or not under Title VII. That's the federal employment non-discrimination law. And many of these other laws that include sex as a protected characteristic, the definition from Title VII is kind of imported into these other laws. So that means courts will likely use whatever the Supreme Court says sex means in Title VII as they interpret other laws in the future, including the ACA. So that basically means, depending on how the Supreme Court goes, gender identity discrimination could be seen as a form of sex discrimination nationwide or not. So that decision will come this term. Many people are expecting it to come near the end of the term in late June, so be on the lookout for that. Then there's the Social Security Act, which sets parameters for state Medicaid programs. And among those parameters are requirements that states provide medically necessary care to people in need and that assistance is provided equally. So these provisions have been interpreted by some courts to require states to cover gender-affirming care. Then there are state-level non-discrimination laws and policies that explicitly include gender identity as a protected characteristic. This is not in all states, but it is in several of the states where the policies on coverage are unclear or there are express bans. And so courts in some of these states have actually looked to state non-discrimination law and have said that that law requires the state Medicaid program to cover gender-affirming care. And then finally, there's the federal Constitution. The Equal Protection Clause requires governments to provide equal treatment to similarly situated individuals. And courts have also used this provision to determine that states must provide coverage for gender-affirming care under their state Medicaid programs. So in wrapping up, I just wanted to talk about what all of these findings sort of mean for people working in the field of advocacy or with transgender patients. So in states where coverage is unclear, providers can play a really big role. They can work within the program to get gender-affirming care services covered. There are many stories out there about people who have found providers that are willing to help them navigate this space and get coverage for their care in these states. In states with express bans or in states where coverage is unclear, advocacy can be an effective tool to bring about policy change. So most of the state Medicaid policies that we considered in this report are issued by the state health department or similar agency that administers the Medicaid program and not through the state legislature. So it's possible to get these policies changed through meetings and other advocacy work with these agencies. It doesn't necessarily have to be a bill that passes through the legislature. And then finally, if people have been denied care or coverage for their care, litigation may be a good option. Lawyers can use the existing laws like the ones we just looked at to argue that their clients should be provided care. And there are several examples of cases like this going through litigation right now in courts, increasingly issuing decisions that address this issue. So that's all I have. Thank you very much. I'm happy to take questions, and there's ways that you can contact us and find us online.
Thanks, Christy. If we have about 1 minute, 1 or 2 minutes for questions. So if anyone has a question, again, you can unmute yourself by either pressing Alt-A, or if you're on a phone, you can press *6. So anyone who has a question can just go ahead and unmute and ask and take it from there.
Well, hearing none, we will move on to our next panelist. Thank you so much, Christy. It is my pleasure to introduce our next panelist, Kayla Renee Gore. Kayla was born in Memphis, Tennessee. She attended Southwest College for Sociology. She's currently the Southern Regional Organizer for the Transgender Law Center in Oakland, California, and Southerners on New Ground in Atlanta, Georgia. Kayla is also a consultant and volunteers with various organizations. She also serves on the board of directors for local and national organizations. She was the lead project consultant for Campaign for Southern Equality's LGBT Health Survey, which is what she will be speaking with us about today. After Kayla's presentation, there will be a few minutes for participants to ask Kayla questions about the Southern Equality Survey. And again, if you'd like to ask questions when prompted, you can press Alt-A or *6 on your phone to unmute. And there will also be, time permitting, some time at the end to have a more general discussion after all three of our panelists speak. So thank you so much, Kayla.
No problem. Thank you, Dale. I'm going to go ahead and start and talk a little bit about the LGBT Health Survey, talk about some of the key findings, some of the highlights, because it's not all doom and gloom. The 2019 Southern LGBT Health Survey was taken by more than 5,600 LGBT people concentrated in the South. They include 13 Southern states. It's the largest survey of its kind, and it's specifically about LGBT people in the South talking about their health and their health care. For LGBT Southerners, we experience many challenges when it comes to health. Our numbers for mental health, depression and anxiety, suicidal ideation, HIV, discomfort when it comes to seeking care are all alarmingly high. We're confronted with these challenges of educating our own providers, which can sometimes be very burdensome. The survey, now it can be used as a powerful tool as we push towards system level interventions all across the South. And we are seeing a lot of advancements. Like I said before, the results aren't all doom and gloom. Some of the answers were quite positive. People rate their physical experiences. Well, their physical health is generally good. People are finding the health care that they seek. And across boards there, the numbers are better for cisgender people, gay and lesbian people, and people with higher incomes. And increasingly, care providers and the American public are understanding more the LGBT people are unique and we have unique situations. Those are great developments. These are great developments, but things aren't moving fast enough. So many people are not getting adequate care that they need. And the survey underlined major alarming challenges. And I'm going to name off a few of those. One of those was more than half of the respondents reported fair to poor mental health, high HIV rates, 5% of the respondents reported living with HIV, and 10% reported not knowing their status. And the national rate of all Americans is 1%. Remember, this is concentrated to the South. Lack of HIV testing, suicidal ideation, 26% of the respondents said they had suicidal thoughts, which is twice as high as the number of Americans in the general population, which have said basically the same, about 14%. Self-harming behaviors, depression, anxiety, almost half of the respondents said they've experienced an anxiety disorder. The national average is 18%. Delaying care, which was one of our biggest categories. 70% of the people who took the survey said they delayed care because of the cost, while nationally, 54% of Americans said they do the same. The survey also shined light on different sub-communities. It shined light on the transgender community and non-binary respondents, respondents with lower incomes of $30,000 or less, respondents in the more rural areas where we know it's harder to reach people to collect data like this. And I'll talk a little bit more about how we were able to capture all of this data. We also highlighted Black respondents. 22% reported that they were living with HIV. Gay male respondents, 13% reported living with HIV. And gay men comprise 73% of respondents living with HIV in our sample. We also spoke with our younger people. People between the ages of 18 and 24 reported fair or good mental health. And that's about 70% of the people who took it. Is my audio still clean?
Sounds like you cut out for a second. It was silent for a few seconds there, but you're back on.
Okay, thank you very much. All right, so yeah, in talking about the ways in which we were able to reach people throughout the South, because a lot of times people are saying that they can't reach people who are in the rural South or in the deep South, but we were looking at really innovative ways of reaching folks, and we talked to people who were club promoters. We talked to LGBT clergy and pastors throughout the South, because we know that these people have like big, large groups of people and big, large followings of folks who were interested in anything that they're behind. So we looked out for leaders within the LGBT community all across the South, and we gave them positions of survey ambassadors. Our ambassadors, we had about 12 to 15 ambassadors collectively, and we paid all our ambassadors a stipend for their work in disseminating the survey link, talking about it in social groups that they hold, talking about it in clubs, in their church congregation. And these were ways that we were able to like steadily increase our numbers, because when we initially put the survey out, it was pretty stagnant. You know, people were taking the survey, but not at the rates that we were hoping that they would actually take the survey. So then we started listing like more niche community holders, stakeholders within communities, like our club promoter, which kind of increased our reach maybe by about 35%, because he promotes all over the South, and he has a text line that he stays in communication with his customer base, and we utilize his text line to send out our survey link and just other information about LGBT health. We didn't want to make it just about the survey. We wanted to see what people wanted as it related to their healthcare living in the South. Quality healthcare is a basic human right. It's one that everyone deserves and should be able to access within their hometowns and not have to go 100 miles just to get gender affirming care. And we know this, that a lot of our respondents in our social groups and our focus groups were saying that they were driving hundreds of miles just to find a doctor who was going to be affirming and that they could feel comfortable sharing personal things with. Everyone cares about their health care, and LGBT people are no exclusion to that. Few things are as foundational as being able to get care you need in the way that you need it, and also when you need it. LGBT people have unique health experiences, as I said before. All people's health and healthcare is deeply personal, but for LGBT people, there often been like a unique requirement for individual exploration and self-education, which is a good thing, but not in the sense of I have to do this in order to have good healthcare so that I can teach my doctor. We have had to fill in the gaps during grade school health classes that have failed to see us. We must seek specific resources to navigate our own communities' disproportionate rates of HIV, mental health diagnosis, and suicidal ideation. We're confronted with the challenge of educating our own providers about our identities and our differences, but we know that change is possible. Many LGBT Southerners are struggling when it comes to accessing quality health care. But the good news is that change is possible. I know what it looks like. I know how it feels when I have affirming quality health care. And we know that every provider in every situation, in every system, can create that space for all LGBT people. And it's the small changes that make the biggest impact. Sometimes it doesn't take enormous changes to make an enormous difference. Sometimes it comes down to a doctor and their staff calling someone by their correct name, using the correct pronouns. Sometimes it's about a patient sharing their LGBT identity and not having to educate the provider on what that means. Sometimes it's about a provider acknowledging that LGBT people face certain disparities and starting a dialogue to connect the dots between the many spheres of healthcare. I can open it up now for any questions that anyone has.
Thank you so much, Kayla. And I just want to remind everyone that if you'd like to speak, to unmute yourself, please press Alt-A. The slide incorrectly says Alt-6, so I apologize for that. Or on your phone, it's *6.
Thank you, Dale.
It sounds like people are being a little bit shy, but one question that I have, Kayla, is can you talk a little bit about how, what some of the report's recommendations are? I was really impressed with the very thorough recommendations included.
Can you be a little more specific when you say recommendations? Are you talking about to providers or talking about like people who are advocating, like some of the folks on this call?
Yeah, I wanted to keep it really broad just because the report includes recommendations targeted to so many different communities, but any that you want to highlight, I think would be helpful.
Sure, let me hit all of them. All right, so everyone can do something to make a difference for LGBT Southerners accessing quality and affirming healthcare. So one is advocate for more inclusive policies in healthcare institutions, training facilities, and in our government. You can educate yourself and providers about how to create an LGBT affirming care environment based on evidence-based practices. Representation is always keen, like training facilities, institutions, and governments can work to build stronger representation for LGBT folks, people living with HIV, and more. Listen to LGBT people and believe them when they share their needs. And talk about mental health, talk about depression, talk about suicide, and HIV testing to reduce the stigma of seeking support. A lot of people, they shy away from these conversations in general settings, and we see that as a problem that like increases the stigma related to all of these topics that I just talked about. They're very taboo in social settings, but we have to like change that narrative so that people are able to talk about their concerns openly and get the help that they need. Because I know for me, a lot of the things that I've been afforded are only because I've been in community with people and been able to talk about the things that I need. And then people are like, oh, you can go here and get that. It's no different for healthcare and the quality of it. Thank you for that question.
Absolutely. Are there any other questions from any participants in the call? Well, hearing none, I'm going to pass it off to Milo to introduce our third speaker.
Thank you.
Sorry, Dale and Milo, I'm just going to interject. We did get one question from the group chat. Living in Nashville, I'm interested if there were, folks were able to get a sense of where the responses were coming from. Any surprises? Kayla, I believe that question is directed to you.
Are you talking about geographically where they were coming from, or?
I believe so.
Okay, so I said for 13 southern states, so that is Tennessee, of course, Alabama, Arkansas, Florida, Georgia, Kentucky, Louisiana, Mississippi, North Carolina, South Carolina, Texas, Virginia. Yeah. West Virginia.
Great, thanks, Kayla. Back to you, Milo.
All right. Well, thank you again, Kayla. That was really fascinating. Our next speaker is Whit Washington. It's my pleasure to introduce them. Whit Washington is an Equal Justice Works Fellow and the creator of the Project for Transgender Incarcerated Survivors at American University Washington College of Law's Center for Human Rights and Humanitarian Law. With PTIS, WIT has worked with volunteer advocates to address the medical and safety needs of incarcerated, transgender, and gender nonconforming folks around the country. Outside of their work with PTIS, WIT has experience working on issues affecting transgender individuals both in and out of the prison context. As a law clerk at the Transgender Law Center, WIT responded to prison mail, addressing the myriad of issues faced by incarcerated transgender community. During law school, WIT was a research assistant for the project addressing prison rape, where they worked with the National Institute of Corrections and leading experts in the field to create a training for prison officials on best practices for incarcerated transgender individuals. Also during law school, WIT testified at the Inter-American Court of Human Rights, arguing that the American Convention supported a self-determination model for transgender individuals to change their names and genders on government documents. WIT has a BA from the University of Redlands Johnson Center for Integrative Studies, an MA in International Affairs from American University School of International Service, and a JD from American University Washington College of Law. And WIT's going to speak about some of their work and advocacy with incarcerated folks. And thank you so much for sharing with us, WIT.
Of course, it's my pleasure to be here virtually. So like Milo said, I am the project director for the Project of Transgender Incarcerated Survivors at American University. Through the project, we've connected with folks in around 26 states. We've had around 200 correspondences, which amounts to around 120 individuals that we've worked with. We advocate on behalf of folks by sending letters to their facility when they're experiencing issues. We've also created a resource to help folks draft more detailed grievances so that the facility knows what's going on with them. Through our work, we've been able to have 3 folks move to safer facilities, although they are now having issues with access to medical needs, so that's still an issue. We're not done working with them. And one of those 3 folks had sent over 100 grievances to their facility, and they'd been completely ignored, and we were able to get a PREA coordinator sent to them to make sure that they were safe and okay. So we're talking about prison, what happens to trans folks in prisons, because as you all know, trans folks are overrepresented in prisons. While 5% of the general population is incarcerated, 16% of all transgender and gender nonconforming folks have been arrested or put in prison at some point, and 21% of trans women are in prisons, and that's according to the 2015 US Trans Survey. So in working with people in prisons, we're looking at, when they're not receiving the adequate medical care, we're looking at an 8th Amendment violation, which means the facility is enacting cruel and unusual punishment. So the standard for that is the facility has caused a significant injury or an unnecessary infliction of pain. When we're talking about medical needs, we're saying by exposing folks to a substantial risk of harm, to a substantial risk of future harm, or they're denying care, or they're giving care that's just so horrible that they might as well have not given care at all. So one of the issues when trying to prove an 8th Amendment claim proving deliberate indifference is that you have to make sure that the facility knows of the issue so that they have warning to act. And so in that, in terms of medical necessity, courts have to find that there's a serious medical need, and courts around the country have been fairly good about finding that gender dysphoria does constitute a serious medical need. When they're looking at that, they're using the standards that they're using, standards of care, the WPATH standards of care, and in terms of diagnosis, they're looking at the DSM-5. And if facilities are denying care, they're only allowed to do so based on medical needs. So they're not supposed to be doing it based on anything else. What I have found, to no one's surprise, is that facilities aren't really adhering to this. So just sort of generally with medical care in prisons, it's very hard to get adequate medical care. We see issues from people not being able to get access to the medical professionals to just, again, not getting very adequate care. So one of the issues specifically with trans folks is that there are a bunch of facilities that have bad policies. So what constitute a bad policy runs from the policy takes forever. In Maryland, there are 9 steps before someone can actually access gender affirming care. And at the lowest end of that, it's going to take 4 to 6 months. So you can imagine that it's probably taking a lot longer for an individual to get access to care. Another bad policy that we see in facilities, it's what we call a freeze frame policy. And that means that folks on the inside can only access care that they had before they were put into prison. And even with that, we're seeing that there are facilities that are very slow to process the paperwork. If someone has paperwork from a doctor, they're taking a really long time to process that and get the person the care that they need. Even when we do see a good policy, we find that a lot of them are not implemented very well. Facilities, like medical professionals, are super quick to say that folks have schizoaffective disorders and not gender dysphoria. And so that's obviously like a big problem. And while the standard of care is that someone can't give care that's so horrible that they might as well not have given care anyway, where we see this not apply, which is super alarming, is that there will be a facility that sort of goes through their whole process of diagnosing someone, and based on their analysis of the qualifications in the DSM-5, someone doesn't have gender dysphoria, so they don't get care. And then there's like an independent mental health professional who does the diagnosis and finds that they have like severe gender dysphoria, and that has actually caused them a lot of problems. Judges don't see that as being incompetent care, which is very alarming, because there are cases where the facility has said this person doesn't have gender dysphoria at all, and then the medical professional from the outside is like, this person has suicidal ideation because of gender dysphoria. And so they're just two drastically different analysis of a single person's behavior that isn't changing drastically between one appointment and another. In terms of access to treatment, access to therapy is very difficult, generally speaking, for all folks in custody. With regard to social transition, I've seen it more successful in jails than in prisons. Jails tend to have better policies. From what I've seen, jails tend to have better policies around sort of everything having to do with trans folks in custody. And we've found that folks who are moved between prisons may get access to clothing and may be able to like keep their hair in a certain style and have access to jewelry and makeup and all that sort of stuff. They can have it in one facility, and then when they're moved to a different facility within the same state, they're not allowed to have it. And so then there's like a whole other advocacy effort to make sure that they can access those things in their new facility. In terms of hormones, as I mentioned, the freeze frame policy, and even those aren't sort of used the way they're supposed to be. I've seen trans men be taken off T because the facility has said that they're too aggressive. And so they've either completely taken them off T or lowered their dose significantly. And also just sort of generally, folks on the inside often complain about their the dose of their hormones having changed a lot from when they were on the outside to when they're on the inside. And it seems like medical professionals are not necessarily listening to folks or taking folks' concerns or needs into consideration. In terms of surgery, we all know it's not very common that folks have access to surgery on the inside. We did see in the Ninth Circuit that a judge did say that it was surgery is a medical necessity and that a facility can't deny that type of care to folks. And that's very exciting. What we often see with these sort of judgments is that folks are released instead of the facility having to implement the care or address whatever issues the person has been dealing with. In terms of sexual assault, the medical and health issues that we're seeing, often they're given medical attention and like only after they're outside of the time frame to access PEP, which is obviously a very big issue as it relates to HIV. And also just folks often are harassed by medical professionals who are supposed to be treating them and taking care of them. So that's pretty much all that I have to say about what I've seen and what I've experienced. One of the things that we were asked for this presentation is like, what can folks do? And so one of my biggest things is working with folks and writing letters to the facility. Black and Pink has a pen pal program, and they will connect you with someone who's incarcerated, and you can help advocate for them that way. Also, my project, we work with a group of volunteers to respond to the folks. That's why we've been able to respond to so many people. So that's another way to get involved, and just helpful resources generally that I found really great. The ACLU of Oregon created a resource, and it's called Laws, Courts, Decisions, and Advocacy Tips to Protect Trans Folks in Custody. And that does a really great job of breaking down all of the legal arguments and issues that trans folks face in custody. And that's all from me.
Thank you so much. Thank you, Whit. That was great. It looks like we have Ash on the chat who has something that Ash would like to mention, and then we'll open it up for questions. Ash, do you want to unmute yourself?
Oh, Ash doesn't have a mic, but I'll read from the chat. Ash asked to mention to folks LGBT Books to prisoners. They send books to persons in custody and or people of color, and or queer folks in prisons. You can write them letters and interact with folks, and just sort of generally, it's a great way to help folks and interact with people.
We also had another question submitted. Have you seen a difference in access or increase in issues between public and private, for example, core civic facilities on access?
I haven't seen much of a difference in access. I will also mention though, we don't necessarily hear from folks we don't hear from enough folks to actually say if there's a difference in treatment, mostly because folks are only writing to me if they're having a problem. So it's sort of every kind of facility that people are having these like a lot of problems, and it seems pretty similar.
There's also been a request to repeat the Oregon resource.
I'm gonna write it out in the group chat.
Awesome. And we'll also send around an email after this following up with resources, and we can include that as well, because it sounds super helpful. If there are no more questions for Whit in particular, we're just gonna open it up to questions for all three panelists.
I have
Oh, great. Go for it, Kayla.
This is Kayla. So I had a question about the access to healthcare. So there needs to be a pre-diagnosis of gender dysphoria before you're incarcerated in order.
I'm sorry, you cut out a bit. I didn't hear what you said. What was the question?
Okay, does there need to be a pre-diagnosis of gender dysphoria before a person is incarcerated by a medical professional, or is that something that they can get inside the jails? And if not, like what recourse is there?
Yeah, so it really depends on the facility. It differs state by state. And so we do see that like the facilities where folks aren't allowed to get access to care unless they have a diagnosis before, you can file an Eighth Amendment claim and address the medical necessity issue, to show that gender dysphoria is a serious medical need, and therefore the facility has a duty under the Constitution to provide that medical need. And we've seen that be successful in various cases.
Thank you. And great
Mm-hmm.
presentation.
I actually just had a question too, about the schizoaffective disorder diagnosis that you mentioned that folks were getting, rather than a gender dysphoria diagnosis. How do you challenge something like that if they're allegedly being given care for something they allegedly have?
So I actually send folks to Transgender Law Center, to y'all. Transgender Law Center has a resource where they can connect trans folks in prison to outside mental health professionals. And so those professionals get access to their mental health records. And then they write a report of like what's up with the individual and what type of treatment they need to receive.
Awesome, thank you. And I promise that was not a plug for TLC on purpose.
No, I meant to plug you for that, and I had forgotten. So I'm very happy that you did give me the opportunity to do that.
Thank you. We have another question in the chat from Chris, who says, if an organization wants to have inclusive policies of trans care, can they be inclusive if there are no inclusive state policies in place? And I'm not sure if this is to Whit in particular or to the other panelists as well, but we can open it up if anyone has thoughts.
I can take a stab at that. This is Kayla. I'm going to say yes, they can be inclusive if there are no inclusive state policies. However, we know that if the state leads with policies, that other bigger organizations within the state kind of follow suit, and it's easier for them to change their policies without a lot of backlash from community. That will be my answer to that.
So thank you from Chris. Something else that we've just been talking about on the coalition was just around gaps in resources and things that folks have seen that still need to sort of be created or that would be helpful for advocacy. All three of you have named some really helpful resources that you use in your work. But are there things that any of you would want to see created or that would be helpful that aren't yet in existence?
Hi, this is Christy. Should I go first? Hi, it's Christy. I was just going to say, and I think we heard a lot of great research from Kayla from a survey, but I would say just increasing data collection on LGBT populations is also super important and allows us at the Williams Institute to do the research we do and allows people developing interventions to know what the public needs. So always asking more questions about sexual orientation and gender identity on surveys.
This is Whit. The resources that I wish there were are more generally for folks in custody. I wish there were some way to create stronger resources that teach folks how to draft complaints. Because we, as you may or may not know, folks in custody who are filing claims are often filing them alone. And in doing research, I see a lot of claims, or I see orders from a lot of claims that have just not been drafted necessarily as clearly as they could be. So I just wish there were stronger resources, maybe intro to legal writing for folks in custody to help them get the treatment they deserve.
In addition to those great things, I would just say some of the things that I've worked on, like locally and regionally, which are resource guides that kind of identify places where other trans folks have had success with accessing healthcare. The guides I've worked on in the past, one of them is really specific to healthcare, and that's also for Campaigns for Southern Equality, which is Trans in the South. It's a guide that's it's online, it's in English and Spanish, and it covers the South, and it basically identifies healthcare providers in all aspects of healthcare that trans folks and LGBT people alike can access these services and know that someone just like them or somewhat similar to them have been there and have said, this is a great place, this is a great resource, you will be affirmed, you won't be ostracized. So like having a national resource like that, I think that will be really, really helpful. I've seen it to be helpful, like here locally we have a Trans Best of Memphis that I created maybe 4 years ago. And it's really helpful. That guide is more comprehensive. It talks about healthcare places. It also talks about places where you can go and find a job, places where you can eat and feel safe and comfortable. So I know that those guides help decrease violence, because we're not going to places that we don't know anything about. We're going to places that have been vetted by someone else in the community.
Thank you so much for sharing that, and that's super helpful. We should definitely include that on the list that we send out after the call. I think we have time for 1 or 2 more questions if folks have any. But yeah. Okay, well, if folks don't have questions now, we might end a few minutes early, and really appreciate everyone coming, and especially the speakers for sharing their time and their wisdom. We're going to send out a whole bunch of resources to all of the folks who are registered, so look out for that. And if you have any questions that come up later, you can reach out to us at TLC or folks at the Harvard Center for Health Law and Policy Innovation, and we'll try our best to answer them, follow up. So thank you so much, and have a great rest of your day.
Thank you.
Bye.